Welcome everybody to our special edition TIF Talk for GERD Awareness. I'm Andrea Millers with EndoGastric Solutions. I'm the Senior Director of Marketing here, and I've got some special guests with me. I've got our Market Development Managers. I've got Lynn McFadden here.
Hi, everyone.
And Karen Girth.
Hi, everybody.
So we're excited. We came up with a campaign called Giving for GERD, and the idea about that is to fight against heartburn and hunger. And we have a great show for you today. We did some street interviews all around Austin, Texas. We're gonna meet with some local doctors, Dr. Trip Buckley and Dr. David Tang. And we have some fun video compilations that we're gonna go through. So we're very excited about that. And Lynn's gonna talk a little bit about the goal and the purpose of our campaign.
Right, thanks, Andrea. So our goal is to raise awareness about both GERD and hunger and food insecurities across America. What we found is that 1 in 5 adults suffer from reflux or GERD, and 1 in 8 Americans suffer from food insecurities and hunger. And also, when you're looking at your food pantries, local food pantries, where these folks oftentimes, if they're struggling with food insecurities, will go for food, there's not really a huge selection of reflux-friendly options. So the second part of our mission is to raise awareness about what some of those foods are, and to also encourage you in your donation efforts this year to consider donating some of those reflux-friendly options.
Awesome.
Thank you, Lynn. So as Lynn explained, this is an EndoGastric Solutions company-wide event. We have encouraged our employees, their families, and physicians to get together and raise awareness for GERD and food insecurity. So take a look at this upcoming video of everyone joining in from Redmond, Washington to New York City as they're giving for GERD.
I got this feeling I can't describe. This magic in the air, the world has come alive. And when I see you, you make my...
Hi, we're here at the Maltby Food Bank in Maltby, Washington, dropping off our company's EndoGastric Solutions food donations because we want to be able to give for GERD and promote awareness for both GERD and hunger. 1 in 5 U.S. adults suffer from GERD, and 1 in 8 U.S. adults suffer from hunger. So this is our chance to support both. Thank you.
1 in 5 U.S. adults suffer from GERD.
1 in 8 adults suffer from hunger.
10.7% of U.S. households face hunger.
60 million people have turned to food banks and community programs for help since the start of the pandemic. Giving for GERD Awareness Week.
So deep, I run, I trip, I fall. I just can't find my feet. If I don't try now, the chance will slip away. I'll bury all my doubts, and I won't be afraid. There's something I could never see. Now my heart is open and I believe, and I don't know where this all will go. Oh, nobody knows. Oh, out of nowhere and into my life, you walked in and you opened my eyes. Can't believe this could happen to me. Yeah. You came crashing in out of nowhere. Oh, this love is straight out of nowhere. Out of nowhere. Out of nowhere.
1 in 5 U.S. adults suffer from GERD. 10 to 15% of GERD patients will develop Barrett's esophagus. 20 million patients are on PPIs and 40% still have symptoms. 1 in 8 U.S. adults suffer from hunger. 10.7% of U.S. households face hunger. 60 million people have turned to food banks and community programs for help since the pandemic.
We are giving for GERD.
Thank you.
Gosh, it's so heartwarming to see so many people within our own company contribute and be a part and participate in our Giving for GERD campaign. So to everyone that contributed and participated, I can't thank you enough. All of our Redmond employees, all of our TIF partners, all of the family and friends. Thank you so much. This is such a wonderful charity event that we're excited about. But did you guys know that 60 million people in the US suffer from GERD? And they come to the food banks or the local food charities for food. And if you just donated $1, it is equivalent to about 12 pounds of food. That's like 10 meals, according to Feeding America, that we could provide to people. So it's kind of amazing the impact that we could all have if we just donated and gave a little bit.
Yeah, such a small amount goes such a long way.
Yeah, absolutely.
Again, thank you to everyone who donated. It was so gracious and over the top. So we've got a couple of examples of some of the bags that were loaded and donated. But when you unpack those bags, we talked earlier about some foods that are friendly to reflux. So we pulled a few of those out for you just to give you some examples when you're shopping and you're getting ready to give for the holidays or at any time for your local food bank. We'll start here with just plain oatmeal. It's always a very GERD-friendly option, and it's rather inexpensive. These items are non-perishable. They'll last a long time on the shelves. They're rather inexpensive for the average American. Here we have some granola bars. Sometimes, chocolate can be a trigger for reflux, but granola bars come in so many flavors. So these are just great items that they can pick up, and they'll last a long time. Some quinoa, some rice. So this is a microwavable rice packet. Again, rather inexpensive and readily available. And then when we're getting ready for Thanksgiving, you think about green bean casserole. For those reflux sufferers, it might not be the best food choice, but these green beans out of the can might be a nice option. So as you're preparing for your giving journey this year, please consider some of these or other GERD-friendly options to donate to your shelter.
Thank you. That's really great, Lynn. I love the examples. Everybody likes to know what's GERD-friendly. So these are great examples. Up next, we did go around Austin, all around Austin yesterday with our team. It was very exciting. And ironically, a lot of the people that we interviewed actually either suffered from GERD and or knew someone that has GERD, a friend or family or member or something. So I was actually surprised about how many people knew about GERD. But catch this video next to see our street interviews. Hey everyone, it's Andrea Millers with EndoGastric Solutions. Thanks for joining us today. We are out here in beautiful Austin, Texas, and we are trying to raise awareness for heartburn and hunger. So we're going around Austin, the town today, and we're gonna ask a couple of people some questions and see if they can get our quiz right to see how much they know about GERD and heartburn, and also the TIF procedure, but also about hunger and how we as a community can help service the people in our community by donating some food to our local food banks. We're here with Layla.
Yeah, hi.
We're gonna ask her a few questions to see how much she knows about GERD. So, first question, do you know what GERD is?
Yes.
What is it?
Gastrointestinal reflux disease.
It's gastroesophageal reflux. Yeah. So heartburn, basically, right? So do you know what symptoms people deal with when they're feeling that?
Well, there's acid buildup, and so they can feel a hole, kind of like they might be having a heart attack. Actually, they feel it's like right here. Sucks.
Okay. Do you know what causes GERD?
Acidic foods.
And so when I say what causes GERD, there are foods that trigger GERD symptoms, but do you know what actually causes you to have really bad acid reflux?
Is it hereditary?
That could be a part of it. Any other ideas?
Like gut biome stuff going on?
No, it's actually you have a valve in your esophagus and it loosens. See?
I know that it like closes and does like that.
Yes.
And then if it doesn't close all the way,
Aaron.
You
get the GERD, y'all. You get the GERD.
Acid reflux. I've heard of that.
Okay. Do you ever take any medication for it?
What happens? I used to eat jalapeno cheeseburgers and go surfing without letting them digest, and then so I was laying on the board, and I guess it would be bad for my stomach. So the cure was not doing that anymore.
You learned something new. Okay, well there you go. Well, awesome. So you guys kind of really know what GERD is and heartburn is. Okay, do you know how it's treated?
I mean,
it's okay if it's wrong.
Sometimes
You're good.
like sitting up for longer and not laying down.
No way, it's antacids, right?
Good.
Okay.
You're both right.
Okay.
Well, it's not treating it, but it's helping the symptoms, right? If you, like you said, if you're laying on your surfboard, you're gonna have regurgitation or have heartburn. But you can avoid some foods, and then you could also take like antacids like Tums or Prilosec. But have you ever heard of the TIF procedure?
Nope.
No. Okay. The TIF procedure is transoral incisionless fundoplication. That's really why we're out here. We have a new procedure that helps treat GERD, the actual root of the problem, not just the symptoms. So that's why we're here. But you guys got like a lot of the questions right. But we want to do one last fun thing with you. So I'm gonna like bring you a piece of food or food item. I'm gonna ask you if you think it's gonna trigger GERD or not. So okay, first one.
We got this.
An apple.
Yes.
No.
Guys, what do you think? It's somewhat acidic, so it could.
I'm thinking apples are sour, especially a Granny Smith apple. You chose that one.
Yeah, I did. Right. Okay, perfect. So thank you. Ding,
She's
ding,
she's all right.
ding, ding. All right, I know. Just wait a couple more years, it'll probably get bad. All right, this is a cup of coffee.
Yes.
Yes, you're absolutely right. It's very acidic, and so a lot of times that triggers acid reflux. All right, next one. How about this brown rice and quinoa? Oops.
No.
It's no.
You're right. This is a really good, brown rice is good. And then we've got, how about?
100%.
Yes.
Yes.
I saw her holding that.
He's like, I'm gonna get this one right for sure, because I could see him holding it. You know what types of symptoms people would have if they have GERD?
My symptom is burning in the throat.
Okay, so do you have GERD, or do you have acid reflux?
I do.
Do you take medication for it?
Yes, I do. Once a day.
How long have you been taking that?
About, I'm going to say at least 3 years, 3 to 5 years.
Okay. Are there certain foods that trigger your GERD?
Alcohol triggers it.
Yeah.
Heaven forbid, don't drink a margarita.
I know, all the fun stuff, right?
Yeah.
Okay. What do you think causes GERD?
Well, I know for me, I have a hiatal hernia, and they told me that was the cause.
Okay, any chance of you getting that fixed?
Well, the gastro guy said you can typically trade one problem for another, that you can no longer belch.
Yeah, so interesting. So that's interesting that you say that, because that is a procedure that gets done. There's a hiatal hernia procedure and then a Nissen procedure that gets done. Generally, is the kind of what everyone used to know about the Nissen procedure, and that does. If they do that procedure, you can't belch, you can't vomit. I know. So it's kind of crazy. So our procedure allows you to do that, and that's why we're trying to raise awareness so people know that there's other options aside from taking medications for the rest of your life and or having a procedure that might give you other side effects. So
do you have any information on that?
I sure do. I'm so glad that you asked.
So do you know what GERD is?
I do.
Can you tell us?
Can't remember what it means. Gastrointestinal something.
Close. Gastroesophageal reflux disease.
Okay.
And so essentially it's like heartburn,
Yes.
acid reflux.
Yes.
Do you know some of the symptoms?
Burning.
That's
all I know.
Burning, you know, do you know some of the triggers? Maybe food triggers?
Spicy food.
Spicy food's one.
Lying flat.
Yeah, all of those are triggers. Do you know what some of the symptoms are that people have that suffer from GERD or acid reflux?
Burping, indigestion, heartburn, maybe.
Do you know how they treat those symptoms?
I'm going to say they probably give them some kind of medication to reduce the acid, or
that's right. That's right. So when people tell you they take Tums or Prilosec or any sort of over-the-counter heartburn reliever. So do you know how to diagnose GERD or how they diagnose GERD?
It's a good question. I don't know that. I think of all the imaging, like CT, ultrasound, X-rays, blood work. I don't know, food sensitivity tests. I don't know.
So you're kind of on the right track. There's different questionnaires that they can use to help diagnose. There's diagnostic testing, such as EGDs, that they can use to diagnose GERD. And depending on how the outcomes are, they just continue to do the testing. Do you know how many people in the U.S. go hungry?
Oh man,
I don't know, like maybe in the millions?
It is. So 1 in 8 suffer from food insecurities or hunger. And do you know how many households are facing hunger in the U.S.?
I'm gonna say another million.
60 million.
60 million, oh my gosh. I was like 2 million, that's a lot, it's a big number.
Do you know what GERD is?
No, not really.
Okay, do you know what heartburn is?
Oh yeah.
Okay.
Yeah, in fact, I'm suffering now.
Oh wow. Okay, so do you take medicine?
Not really. I have been suffering this for the last 5 months.
Okay.
From time to time, I just take some Tums or probiotics. In fact, I'm taking probiotics now.
Okay.
So I have been taking them almost 3 months.
Okay. The second question I'm going to ask you is, do you know what causes heartburn or GERD?
Oh, I have listened that it's because the kind of food you're eating.
Okay.
Or maybe the schedules in which you're eating those foods.
Okay. Do you know what foods trigger acid reflux?
I have noticed that sometimes chocolates, which I'm a fan.
Yeah, I know. Are we all right?
We're all fans. So I think that's something that really makes me feel really bad.
That was so fun to go out into the streets of Austin, Texas, to talk to everybody on the street, to ask them if they know what GERD is and the TIF procedure. It was very interesting to see that so many people knew what GERD was and didn't know what TIF was. So it was nice to be able to explain what the TIF procedure was to them. So up next, we have 2 physicians that we will be talking to. We've got Dr. Tripp Buckley, who is a surgeon, and Dr. David Tang, who is a gastroenterologist. So we'll have 2 perspectives on the discussion around GERD and the TIF procedure. So please keep watching. Hello and welcome to our TIF Talk tonight. Thank you for joining us. We're very excited. We are actually here on campus at the University of Texas at Austin. What a beautiful campus we're at. Ascension Seton and UT Health Austin Digestive Health. And today we're very excited to have our special guests. We have Dr. Tripp Buckley and Dr. David Tang. Thank you so much for being here. We're very excited.
Thanks for having us.
Thank you. So before we start, I do want to give a little bio of both Dr. Buckley and Dr. Tang so you guys know where they're coming from, and then we'll talk a little bit more about your program here. So Dr. Buckley is the Surgical Director of Digestive Health, a clinical partnership between Ascension Seton and UT Health Austin, the clinical practice of Dell Medical School at UT Austin. He's an associate professor and director of the Heartburn and Esophageal Disorder Center at Dell Med, and specializes in anti-reflux and esophageal surgery, assisting patients suffering from gastroesophageal reflux disease, otherwise known as GERD. And Dr. Tang is a gastroenterologist at Digestive Health and an assistant professor in the Department of Internal Medicine at Dell Med. He specializes in the diagnosis and treatment of patients with pancreas and biliary conditions and disease, as well as acid reflux. So again, thank you guys so much for being here. We're very excited to talk with you today. So before we start, I'm going to kind of let you guys talk about your program here and what you do and who you see. So I'll let you guys take it over.
Sure. Well, this is really exciting, so thanks for having us again. When Dell Medical School's brand new, and when I was recruited here, one of my goals, having treated reflux disease and GERD from a surgical perspective, was really to bring GIs and surgeons together. And so that was the concept behind Digestive Health. And so that clinic has GIs and surgeons working in the same space. Again, we have a medical and a surgical director, and we do everything in lockstep together. So that's super exciting. And then under Digestive Health, we have the Heartburn Esophageal Disorder Center, which again is GIs and surgeons working together, collaborating to diagnose and treat patients with GERD and other esophageal disorders. So Dr. Tang and the GI group are integral to our success, and we were lucky enough to recruit Dr. Tang as well, and now we're doing lots of procedures together, including the TIF procedure.
Yeah, thank you. And I want to agree with you that one of the
It's a
most
first.
one of the most impressive things about our program at Digestive Health is that we're able to bring together gastroenterologists and surgeons. We're literally in the same space, and we work together not only taking care of the same patients, but also in the background developing protocols to more effectively and efficiently and streamlining the care of patients with heartburn and esophageal disorders certainly, but with lots of other digestive disorders as well.
That's fantastic. Yes, the collaborative approach is rising in popularity for these patients. We're having a foregut surgeon and also a gastroenterologist kind of collectively looking at the patient and personalizing the approach of treatment for GERD. So you guys are in good hands today because we have both perspectives. So we're very excited. So let's go ahead and start and talk about GERD. What is GERD, and what are patients generally suffering from if they have GERD?
Yeah, well, to me, GERD is acid reflux that causes frequent and bothersome problems. So acid reflux is when stomach acid travels back upwards into your chest and your esophagus, and it happens to all of us from time to time, but when it happens very frequently and it results in a lot of symptoms, then we call it GERD. And it can cause lots of different symptoms. Some of the classic symptoms of GERD are heartburn and regurgitation. Heartburn being burning in your chest, and regurgitation is that feeling of stomach contents traveling backwards and washing up into your chest and mouth.
Sure, yes. And oftentimes patients or physicians even talk about what do we call it, like LPR or non-classic symptoms. Can you talk a little bit about that? Because there's a lot of patients that ask about LPR or non-acid reflux.
Yeah, definitely. So what I just mentioned, heartburn or regurgitation, are considered the classic symptoms of acid reflux or GERD, but there's certainly lots of different symptoms that can be attributed to acid reflux. And this is, I think, where it's very important to have objective testing. So a lot of these symptoms have to be, we have to differentiate them being caused by acid or them being caused by something else. And thankfully, there are ways to objectively measure, for example, how much acid enters your esophagus or mouth. And in that way, we don't have to guess. We can know for sure whether or not your symptoms are caused by acid reflux or not.
Perfect. Do you want to talk about the diagnostic testing that you do to determine if a patient does in fact have GERD?
Yeah, if you have classic symptoms and you've never been treated before, then the diagnostic testing is in essence clinical judgment. So we will say that, hey, you have heartburn. It sounds like heartburn. We'll give you some medications and other advice, and see how you do. But if that doesn't work, or if you have these atypical non-classic symptoms, what we generally do, one of the things we do is pH monitoring. So in that situation, we would actually place a small sensor inside of your esophagus. This can be done with or without a camera test. And then over the next few days, 2 days or 4 days, we monitor how much acid enters your esophagus 24/7. And then you can also tell us when you have a symptom, or when you're eating, or when you're laying down, and then we can try to match up those symptoms with acid entering your esophagus to see if those symptoms are well matched up in timing with acid entering your esophagus. And that's the way we can determine objectively if most of your symptoms are from acid and proceed from there.
Thank you for that. And you guys have a somewhat unique approach to it, right? Because if a patient was suffering from GERD, would they come see you as a GI first, or would they come see you, Dr. Buckley, as a surgeon? How does that collaboration actually work, if you don't mind?
Yeah, I mean, in some ways, it's we have two pathways, and we have a number that you can call, and our folks that answer the phones are well trained in trying to differentiate. Do you need to see a surgeon? Do you need to see a gastroenterologist? A lot of our folks have never seen a gastroenterologist, and so they're calling in 512-495-GERD, and they do it all the time. We've got 5 people answering the phones. But if you've never seen a gastroenterologist, we're going to start with GI and kind of go through lifestyle modifications, maybe medication, as Dr. Tang mentioned. Some patients are calling and they've been to multiple gastroenterologists. They've been to their ENT doctor talking about, as you said, LPR or some of the atypical symptoms of GERD, in which case they might end up on our side of the clinic. And so it really doesn't matter, because as also Dr. Tang alluded to, we want to say that it doesn't matter if you see Dr. Tang or me, we're going to have the same treatment pathway for you. So you go onto a pathway and whatever's the best treatment for you. And we're focused here at UT Health Austin on outcomes that matter to patients. And so we're looking to figure out what your goals are and how we can meet your goals. And sometimes that might mean surgery, sometimes that's medication, optimization, and things of that nature. Sure. We also have, we have nutritional medicine and nutritional therapy, as well as cognitive behavioral therapy, for patients, to give them the tools to, kind of fight their disease process.
That's fantastic. Anything else that you wanted to add to that?
I just, again, I think that's a very important point, because I think Dr. Buckley put it very well. It's the same pathway, and we want it to be the same pathway. We want to tell patients the same sort of things, but you may enter that pathway in different places. So as Dr. Buckley said, if you've never seen anybody for heartburn, then you may see me or one of my colleagues. But if this is, you've suffered from heartburn for a long time, if you're really you are looking for a surgical solution, or if you had a surgical solution and it hasn't been working well for you, then you probably see Dr. Buckley first. But at the same time, we're in the same place. We talk to each other, and I think that's very important for the patients to get that unified message.
I love that. Yeah, that's great. Thank you. You did mention kind of the pathway. You kind of went through the pathway just a little bit, but can you talk about the different options for treating GERD? So, at first you were talking about lifestyle modifications and food aversions and whatnot if you do have GERD, and then how does that progress, medical therapy all the way to potentially having a procedure? Do you guys want to touch on that?
We'll start here. I mean, I think everybody needs surgery, right?
Right.
No, I'm kidding. That's not it at all. But no, I mean, I think Dr. Tang can speak best to the lifestyle and possible medication treatments.
I think, for most people with heartburn, the foundation of therapy is lifestyle modification and medications to some extent. On the side of lifestyle modifications, one of the most important things is to look at your body weight, actually. So we find that patients who are overweight or obese can have a lot of pressure on their abdomen. You can think of it as a hand around a squeeze bottle, and you can squeeze acid up into your chest and cause a lot of symptoms. Other lifestyle modifications exist, including not eating meals right before bed. Sometimes one of the most effective things is to just elevate your head and shoulders at night, especially if your symptoms are at night, and a number of other lifestyle alterations. There are dietary alterations as well, although sometimes those are very individualized, so not everything applies to every patient. On the medication side, certainly if you have heartburn and you've never been treated before, we will recommend that you start with an acid-suppressing medication for a certain amount of time. But I think in that situation, it's important for us to really follow up with you and see if it's working for you or not. Sure. Because if it is, and if you want to continue it, and that definitely can be the way to go. But if you're not satisfied with it, or if it is working, but you just want a longer-term solution, then I think perhaps other procedural interventions can be discussed.
So before you go into procedural interventions, I do want to ask you, because I know that, and it's close to me because this is where I am at in my journey of GERD. I went to see my general practitioner, and I have not seen a GI yet for my GERD, and I've been on PPIs. At what point, and I think there's a lot of questions from patients, what point should a patient decide it's probably time for me to, go see a gastroenterologist and determine you really do have GERD, because there's a lot of talk and a lot of conversation about long-term use of PPIs. So just curious to see what your thoughts are on that.
Yeah, I think as far as when to see a gastroenterologist, I think if you've been on acid suppressing treatment and you have questions about it, or if it's not working for you, or if it is working for you and you wonder if there's anything else to do, then that would be the time to see a gastroenterologist, certainly. And long-term safety of proton pump inhibitors, PPIs, is definitely a very serious topic, and it's one that gastroenterologists and other physicians have investigated in detail over the last several years. I would say that we have to look at there's two things we look at in that aspect. One is, does this association exist at all? Because there are some associations that have existed in some studies and not in other studies. And then we also have to look at the degree of how you're affected with these things. So some adverse events, you're at a risk for maybe about 20% more or 30% more, which seems like a lot, but in absolute numbers, maybe you went from 4 out of 100,000 to 5 out of 100,000 chance. So the standard advice I give patients who are worried about chronic PPI use is to make sure, first of all, that you are on PPIs for a good reason. So, for example, if you have classic heartburn and or classic GERD symptoms, and you are on a PPI and it's working for you, then it can be an option to continue. Although I would say that if you are worried about the long-term side effects and you want to explore other therapies, then that definitely is a very, very legitimate pathway to go down as well.
Yeah. I feel like you're talking directly to me.
He was, in fact.
He was, wasn't he? I'm taking it a little personally over here.
And our friends out there.
Yes, absolutely.
And if I could just add to that,
Yeah.
I think that when you think about PPIs, it's really easy to dumb down GERD into just simple, I've got GERD PPI, and it really becomes complex. So to your question, like when to seek additional advice, your gastroenterologist, there's lots of different strategies to, start with a PPI and then come down to the lowest dose. I mean, some people are started on the most powerful PPI right out of the gate. Well, maybe we can get you on the lowest dose, or maybe we can get you onto an H2 blocker, like Pepcid or Zantac, which is back on the market, or down to lifestyle modifications plus occasional, Tums Rolaids and things like that. So, I think that's where it becomes a little bit more sophisticated and possibly within the realm of PCP, although they're really busy. So, to go to somebody who is dedicated to that disease process might be a legitimate answer.
I love that. I love that. So now on to the fun part, right?
Yeah, oh yeah.
Let's talk about the procedures, or what are the different options that are available today for the treatment of GERD? Obviously past, medical therapy and food, lifestyle modifications, whatnot, and then moving into kind of what's available today.
Sure. I'll pick up where David left off, which is, PPI therapy. PPIs are highly effective at treating the symptom of heartburn, and most people are going to get relief when they take their PPI appropriately, and that's the other part of PPI therapy, is taking it appropriately. Absolutely. But we also know from the GI data that about 30 to 40% of patients are going to have breakthrough symptoms on that PPI. Well, do they just need a little extra help in terms of timing or lifestyle modifications, or are they truly, we don't think about them as truly refractory, that's a term out there, refractory to PPI therapy, but rather, are they just breaking through? Do they have regurgitation that PPIs are not going to take care of? Because of course, any medication is not going to stop reflux, it just is changing the symptoms. And so if our goal is symptom control, from a heartburn standpoint, PPI should take care of most of that. And again, GERD gets pretty complicated pretty quickly. I mean, some patients have a hypersensitive esophagus, so that's where either on our side, on the surgery side, or more commonly on the GI side, we can treat the hypersensitive esophagus as well. And so not everybody needs surgery. The residents always joke with me, like, how many more people are you going to talk out of surgery in clinic today? And we really are looking for that ideal patient from a surgical standpoint. But when you think about surgery, the data is clear that surgery is as effective and probably more effective than medication in the treatment of just long-term GERD. And that's actually in the current GI guidelines. There are new GI guidelines coming out, and I'll put a plug in for the American College of Gastroenterology and the group led by Phil Katz, but those guidelines should be out even as you're watching this. So you can go onto the American College of Gastroenterology and look for those new guidelines. We're really excited to have updated guidelines. But so, theoretically, you could apply surgery to probably about 14 million, Americans out there today. Is that the best thing? It's not actually the way I practice. So even though, we do over 200 anti-reflux cases a year, I think I'm gonna do around 260 or more this year. We don't apply it to someone just coming in saying, hey, I think I'm just not happy on my PPI. We really try to look at their needs, and then we go through the objective testing that Dr. Tang mentioned. So pH testing, esophageal function testing, so that's often manometry. And so we have all that stuff here in one location, and so it's really nice. When it comes to surgery, we have also a lot of different types of surgery that we can look at. There's the classic fundoplication. Most people know about the Nissen fundoplication, and there's really about 10 variants that I actually perform here, and that become a little bit more customized to patients' needs. Those have a very bad reputation out there, and somewhat deservedly so. Unfortunately, the data from large centers like our own is that those surgeries work, and they work well. But it takes a lot of expertise, a lot of training to get good at them. And so they have, unfortunately, a bad reputation, because out in the world at large, sometimes the outcomes don't match the data. So that's also bred a lot of different types of alternatives. So you can have radio frequency ablation and therapy down at the lower esophageal sphincter. There's something out there called LINX, which is a magnetic beaded bracelet. There's, of course, the TIF procedure, which seems to marry the best between GI and surgery. And so we're really excited to be able to offer the TIF procedure, but also literally everything under the sun here at UT.
Fantastic. Let's talk about the TIF procedure a little bit. That's why we're here today. So maybe Dr. Tang, you can tell us how it works. And also, we didn't mention the hiatal hernia part of it. And do you want to maybe discuss that a little bit?
I'll touch
together?
on that after Dr. Tang talks to us a little bit about TIF.
Yeah.
So TIF, transoral incisionless fundoplication, is a fundoplication like Dr. Buckley was talking about. And so a fundoplication is, correct me if I'm wrong, but it's where you take the fundus, the top part of the stomach, and kind of wrap it around itself and recreate a bit of tension in your gastroesophageal junction. And TIF, the device, allows an endoscopist to do that from the inside of the esophagus. It's for an experienced endoscopist, it's actually a fairly straightforward procedure, and actually the results, at least from the inside of the stomach, look very, very good. So I think it's exciting because for me, it's like we're talking about collaboration on the clinical side. Gastroenterologists, we don't, when we come to procedures for GERD, we mostly do the diagnosis and the testing and not so much of the therapy. And so this allows me to participate with Dr. Buckley in the direct therapy of someone with heartburn as well.
That's fantastic, yeah.
Yeah, so, the procedure, the TIF procedure, there is a small segment of folks that would benefit from just a straight TIF. Right. However, what we've learned, especially more so in the last 5 years, but really going back a long time, is that the Gerd Barrier is two components in its simplest form. So one is the diaphragmatic pinch, and then there's the lower esophageal sphincter. And so often patients have a hiatal hernia. And even if you can't see a hernia on an endoscopy or some other diagnostic test, usually the diaphragm is radially dilated, so there's just a little bit of opening, so it's not pinching the way it should.
Sure.
So we really think about all of the surgical therapies involve fixing two things. One is that diaphragmatic pinch and a hiatal hernia, and the other is addressing the sphincter. And that's the beauty of the combination TIF procedures, that we're addressing both.
Sure.
So myself as a surgeon will go in and repair a hiatal hernia, and then I think this is another key, is bringing down the lower esophageal sphincter well into the abdomen.
Sure.
That does two things. One, it creates a lot of length, and without getting into a lot of physics, you know, that the longer your length of the Gerd and the Gerd Barrier, the better the patient's going to be, and hopefully there's a reduction in risk of a recurrent hernia. And then Dr. Tang does his magic from the inside, and I'm a big proponent of this collaborative approach, because I think while I do endoscopy and I have a skill set there, I think it's best left to the pros, and then it also helps with that patient, because now we own that patient together. And we've been doing it for a little while, and it's been fantastic, and we're really excited to be participating in some research studies as well, which is our approach here in general.
Fantastic. Well, thank you. Can we talk a little bit about post-op? You know, patients often wonder, what is it going to be like after the TIF procedure? I've heard about this TIF diet. Is it going to be really that bad? What are the things that you recommend for patients for the diet, A, and then the second thing is, what is post-op as far as physical activity goes? Can they go back to work right away? Do they need to stay away from doing certain exercises? So I would suppose it might be different with a hiatal hernia repair, or it may not be. So I'll let you guys kind of discuss that.
Yeah, I mean, we do all of ours in combination as a combined procedure, because we feel strongly, again, that that diaphragm plays a big role, whether you can see a hernia or not. And so really the post-op is very similar, if not exactly similar, to that of a fundoplication. And you're right, patients kind of get freaked out about the diet, so I'll kind of just go through it. But basically these are day surgeries. So you come in on a day's surgery, go home same day. They are not debilitating surgeries at all. I've undergone 2 anti-reflux procedures myself, and I was back operating 6 days after each.
Superman over here. Don't tell these patients
No, I'm
that.
a wimp. Anyone will tell you that. And so, you know, any surgery is, you know, anxiety provoking and a little scary, but at the end of the day, the recovery is very fast. We have patients on a liquid diet immediately post-op. And that sounds terrible too, but having been through it myself, I can tell you it's not. And it's interesting because the part of the stomach that we use to create that fundoplication, whether it's a classic laparoscopic fundoplication or that by the TIF, that area of the stomach is what sends out signals of whether you're full or not. So patients really are just not that hungry.
I've heard
so,
that. Yeah.
You know, it's really not a bad week. But any liquid
and
is okay.
Lose a little weight.
Patients do tend to lose about 10 to 15 pounds, that's right.
Okay.
And it's not, again, because they can't get the calories in, it's just that they're not particularly hungry. Yeah. And then it's just a progressive diet, so usually by 4 to 6 weeks you're back on eating normal things. Sure. We always tell folks you gotta slow it down, because we have recreated that sphincter and we've got an obstruction there, both to reflux but also to food. So if you were like me and a food inhaler, you'll learn quickly.
It's all the good food here over here.
You just gotta slow it down is all. And activity-wise, you know, it's just no heavy lifting greater than 10 pounds for 3 weeks. But really, we want people up, moving around, and being their normal selves.
Yeah, wonderful. Thank you. Interestingly enough, I heard another doctor say something about chewing your food. So it's almost like a lifestyle change, if you will, that they say get back to kind of eating healthy and trying to not have big meals and smaller meals at more periodical times or whatnot.
Absolutely. I mean, that's why we have our nutritionist involved in the vast majority of our patients. So she's helping them both preoperatively and postoperatively.
Oh, fantastic.
And you know, again, to the weight issue, we are working with them on, you know, again, on all fronts to really help out and get you through that and get some good healthy habits moving forward.
Healthy habits, absolutely. So one thing we get a lot from patients is what happens if you don't treat your GERD, untreated GERD. You know, you may want to touch on Barrett's. I mean, I know it's not a direct correlation, but then also I'm saying that because GERD Awareness Week is this week during Thanksgiving, you know, when we're most gluttonous, eating our turkey and casseroles and whatnot. And then we also kind of had awareness around esophageal cancer, which was in April. Can you kind of talk about the connection of not esophageal cancer, but what GERD, from GERD to Barrett's to, you know, I'll let you talk about that, Dr.
Yeah,
Tang.
so there's a number of consequences that have been connected to uncontrolled GERD. But the vast majority of people who don't control their GERD just only have symptoms, probably about 80%. And so in those patients, even if you feel very poorly, even on the medicines, when we do endoscopy on you, we will find a normal esophagus. But I think that's, you know, that's bad enough if you have to suffer through daily life with, you know, debilitating heartburn symptoms. It is also associated with actual damage to the esophagus as well, to a much smaller degree. You can have damage in the esophagus we call esophagitis. That itself can lead to other consequences, such as a scarring or narrowing of your esophagus. You can also be associated with this condition called Barrett's esophagus, which is the change in the lining of your esophagus from normal to something that's not normal. And that itself may place you at a higher than average risk for esophageal cancer. So there's not a there's not a one-to-one. So I don't want you to think that if you don't control your heartburn, you're definitely going to get Barrett's esophagus, and then you're definitely going to get esophageal cancer. That's not the case, but it is those things are associated to some extent.
Yeah, I have Barrett's myself, so I've got all the GERD things.
The GERD things.
So about 15-20% of patients with GERD will have Barrett's esophagus. And Barrett's esophagus, as Dr. Tang said, is, you don't have to think, oh my gosh, I'm going to die of esophageal cancer. But it's exactly like having a colon polyp. And so, to your point earlier of when to go see your gastroenterologist, I mean, you really want to go find some professional help, see your gastroenterologist, because if you're had GERD for 5 years and it's you've been treating with PPIs, you still, I would personally, it's not exactly in the guidelines, but I personally would recommend that you could have an endoscopy, and to make sure you're not covering something up. I mean, most people that develop Barrett's and esophageal cancer have been on PPIs and they've never had an endoscopy. So, and if they find Barrett's, then we're going to put you in a follow-up program. And so just like with a colon polyp, we're going to do endoscopy to make sure that Barrett's is not progressing onto cancer. So, Barrett's is not, to be taken lightly, but it's not a death knell or something like that. And we do get a lot of patients coming in saying, oh my gosh, I've got Barrett's, I need surgery. Surgery is not an anti-cancer operation. I think there's more data coming out to suggest that for sure surgery is more effective when you look at Barrett's than medication. In terms, we often see regression, and we again map that every time we do an endoscopy, and I think we've got some data coming out on that, and there is data out there already. So I think that Barrett's is just a harbinger that you've got significant and severe GERD, and you should be followed. So I think that's the big take-home point there.
Thank you. One of the whole reasons why we do these TIF talks is to raise awareness around GERD. And I think one of the biggest things we tell patients is to be your own advocate, right? There's no, with colonoscopies, right, 50, now it's gone down to 40, everyone should get it. They don't have that kind of guidelines, right, for upper GI. So we want to just educate the population about GERD. And if you are suffering, there are other options from just being on medical therapy forever, or just you could never have your favorite glass of wine anymore, and or that spicy food or the barbecue here. So before we conclude, I do want to give you both an opportunity to, if you had one word of advice to patients that are out there that are suffering, and don't look directly at me like you're talking to me about this, I'm just kidding. But no, seriously, if you had any advice to the patients that are watching today, what would that be?
If you have heartburn and you have symptoms that you're not happy about, then you don't need to suffer in silence or try the same thing, year after year and for a long time. Come and see a gastroenterologist or a surgeon, see a professional who deals with these problems all the time. And there may be plenty of things that we can do for you to investigate your condition and to help your condition. So I think that would be my big message.
Fantastic.
I'd probably have the same message. I'll just emphasize that, from an economic standpoint, GERD is only second to all digestive cancers in the economic impact in the U.S. GDP. And whether it's sleep deprivation or missed work, lethargy, and then just pain and suffering. And so, yeah, go and seek out some help. Because the answers are out there, and there's lots of different treatments these days for that. And I think at the end of the day, it's about improving quality of life, and the answers exist. So we're happy to help, and I'm sure your local GI and/or surgeon is happy to help as well.
Fantastic, thank you. Well, that is a perfect segue. If you are suffering from GERD and you're in the Austin area, obviously you can come see these fine physicians here. But if you're not in the area and you're trying to find a TIF-trained physician, you can go to our website. It's gerdhelp.com. There is a physician locator on there, and you can put in your zip code, or you can search by state, and you'll be able to find a TIF-trained physician near you. So again, we can't thank you both enough for joining us today. In the beautiful, sunny Austin, Texas. Thank you so much. We at EGS really appreciate it. I know the patients that are watching also appreciate it. Wasn't that exciting, everybody? Thank you guys so much for joining us for our special edition, Giving for GERD TIF Talk. There is a button below, and if you want or are looking to donate to Feeding America, you can click that, and you'll be able to donate either monetarily, your time, if you want to donate food. Please, we encourage you to go ahead and do that. And 100% of the proceeds goes to Feeding America. So we hope that you could help support our cause in the fight against heartburn and hunger. Again, we can't thank you enough for joining us. We are here every Tuesday night. So if you ever want to watch another TIF Talk, we'll be here. But I know from the bottom of my heart and my team that's here with me, Karen, Lynn, and our newest member of the team, Salome, say hi. We thank you very much. We hope you have a fantastic holiday season. Enjoy Turkey Day, and we'll catch you next time. So thank you very much.